Hi everyone, my name's Joni O'Connell. I am Head of Paediatric Audiology and Clinical Scientist at the Children's Hearing Centre in Bristol, and I've been asked to give you a little presentation today on Down syndrome and hearing. This is our agenda for today. We'll start to look a little bit why hearing matters so much and what we do in audiology with our hearing checks. Types of hearing losses we might find, before concentrating a little bit on why hearing is so important in the Down syndrome population. I'll talk about spotting the signs and ways you can help at home, discuss the various different types of hearing aids on offer, before moving on to some top tips and lived experience around audiology appointments and hearing aid use. Before finishing off with some useful resources. So why does hearing matter? Well, we know hearing and listening begins before baby is even born. As early as 16 weeks gestation, baby can recognise and respond to mum's voice. We know the first 12 to 24 months is absolutely critical for speech and language development. It's known as the critical time window or critical period. And it's vital that a child has good access to sounds, good consistent access to sounds during this time in order to develop their speech, language and listening skills. If children have undiagnosed or unmanaged hearing loss during this period, they can experience lifelong consequences. So we know hearing loss can delay speech and language, but that has knock-on effects such as impact on school readiness, literacy, and numeracy skills. For those with additional needs such as Down syndrome, the challenges are often compounded, leading to a broader range of difficulties that can affect every aspect of their educational and emotional well-being. These include behavioural difficulties stemming from frustration or communication barriers. Children may become withdrawn, preferring to play or be alone. We have reduced self-esteem due to feeling misunderstood or excluded, increased vulnerability to poor mental health, limited ability to reach full academic and personal potential, and poor attention due to increased listening effort. We have lower overall educational attainment compared to their hearing peers. And we know this all seems really bad, but we know early detection of hearing loss and treatment and support leads to better outcomes for all children, particularly those with Down syndrome. What is audiology? So some of you may be well versed in what audiology is and have years of experience of going to an audiology department. But for those of you who are more new to this, audiology is a study of hearing and balance. Those of us who work in the industry are known as audiologists, paediatric audiologists, or clinical scientists. And we diagnose hearing problems, both permanent and temporary, and we offer advice on treatment. When hearing loss is identified, we work closely with teachers of the deaf, or they're sometimes known as hearing support teachers. And they're a fantastic form of support for you as the family, and they act as a go-between really between us and clinic, your education provider, whether that's preschool or school, and are there to support you. Moving on to the types of hearing tests we do in audiology. So we have two main types of tests. We have objective tests, which do not require a baby or a child to do anything, which are particularly useful in newborns and very young children who are unable or do not want to complete our other hearing tests. You may well have seen all of these or some of them, but we'll just have a look at each one in a little bit of detail. So the first one on my list there is tympanometry, and you can see a little girl having that done. It is a measure of how well the eardrum is moving. This is a very simple but very important test that we do pretty much every time your child comes into clinic. And it will tell us whether basically that whether your child has glue ear or not. It involves putting a little earplug in the ear, and there's a puff of air or a little bit of pressure put through the ear, and we can see whether the eardrum is moving or not. If the eardrum is moving, it tells us that everything's working nicely. If there's no movement of the eardrum, it usually means there's a bit of fluid or congestion in the middle part of the ear. The second test we've got here on my list is otoacoustic emission testing. And that will look very similar to our tympanometry. We put a little earplug in the ear. But this time we're sending a sound into the ear and the machine is listening for an echo back. If that echo comes back, it tells us not only the inner ear is functioning pretty well, but the middle ear is functioning pretty well with no obvious signs of congestion or glue ear. And whilst it's not as detailed as our other tests that we're going to come on to, it does rule out a significant hearing loss. And then we've got a baby here who's having an auditory brainstem response. You may well remember this following your newborn hearing screen if you were referred into Audiology. And on this test, we put little stickies on the baby, attach them up to our machine. They have to be fast asleep, and we play sounds through some little headphones and measure a response from the hearing nerve. Occasionally, we will suggest this for an older child, but this would generally require some sort of sedation or general anaesthetic because older children don't tend to fall asleep in the day. And you might be offered this if there are particular concerns about hearing or speech, and we are unable to determine a hearing level via our other tests. The second category of hearing tests are called behavioural. Behavioural hearing tests are ones where a child has to do something in response to a sound. And we can't start behavioural testing until a child is about 9 months old because they need to sit up on their own and they need to turn in response to a sound. And when they get this right, they're rewarded with a flashing light or toy. And this is called visual reinforcement audiometry. Now, children with Down syndrome tend to start doing this test around the age of 12 to 15 months. So just very slightly later when compared to children without Down syndrome. We sometimes do this test just playing the sounds into the room. So we're testing their overall hearing using both their ears. And sometimes we can get headphones on them so we can start to test each ear on its own. And it really depends on how well the child is what we call conditioning to the test. So you might hear an audiologist talk about conditioning. This is when we're teaching a child to turn in response to a sound. And we condition at quite a high level of sound, one we know they can definitely hear. Then once your child has got the idea of it, so they're conditioned, we turn the level of the sound down and we find the quietest level that your child responds to, and we can change the pitch of the sound and get a really good idea across all the different frequencies that are important for their speech. Now, I've included here a video just in case you haven't seen this in action yet. Do have a look at that if you're particularly interested. So from about the age of 2.5, again slightly later for children with Down syndrome on the whole, not always, children no longer complete visual reinforcement audiometry or VRA, and this is because they're just bored by it. So they're not interested enough by the sound or the toys, and they very quickly disengage and stop responding. So we do something a little bit more interesting and engaging called play audiometry. So in play audiometry, again, we play the sounds either into the room or through headphones, and we get the child to play a game in response. So this could be throwing a ball in a bucket, putting a man in a boat, or if you can see here our model who's putting little flowers into a cactus. It could be literally anything. Sometimes we tailor this to a child's particular preference. So if your child loves cars, we can integrate cars into the game. So if you have any ideas, please do bring them if you feel that we would get more out of your child in their audiology appointment. Again, there's a little video there showing you the conditioning phase of this test. As you can see, when you do have a look at the video, conditioning can take a little bit of time. Sometimes that's all we manage to do in a session, and it's not until the next time they come in that we can start to do the test proper. One way we ask parents to help with this is to practice it at home. It doesn't really matter what activity you choose, what level of sound you use, it's all about practicing the game. So if in clinic we're struggling to get any test results, this is something you can be doing at home. So practice with one of their toys to you saying go, and getting them to wait until you say go is really, really useful. So once your audiologist has done all those tests, they've put all those pieces of the puzzle together, hopefully they'd be telling you whether your child has good hearing or whether they've detected a level of hearing loss. So in order for you to fully understand what audiologists go on about, I thought I'd spend a bit of time about what the hearing pathway, what happens when it is functioning well, and the types of hearing losses that your audiologist may well discuss with you. So in a nutshell, our hearing pathway converts sound waves in our environment into messages that our brain can understand. And the ear has three main parts. We've got our outer, middle, and inner ear. And all three parts need to be working well in order for us to hear well. So what is the hearing pathway? Well, sounds are generated in our environment, and that creates sound waves. The pinna funnels these sound waves pinging around here into our ear canal. The ear canal sends these vibrations to the eardrum, which is a very thin film of almost like cling film, tightly pulled cling film. And these vibrations move the eardrum, which sends the vibration message down the three ossicles there in the middle ear. This in turn then vibrates this fluid that's in here. Okay, this is a snail-like structure called the cochlear or hearing organ or inner ear, and that vibration sends a rippling effect in the fluid, which runs over these tiny hair cells that line this hearing organ. And those tiny hair cells start to wiggle around and generate electrical energy. And it's that electrical energy that is pinged up the hearing nerve here to the brain. And the brain uses all that information, puts it all together, and interprets the sounds in our environment. So quite a fascinating, complex system. There are two key differences in the ear of a child with Down syndrome. They have smaller, more narrow ear canals than a child without Down syndrome on the whole. They also have very small, narrow eustachian tubes. Now, all children have narrow eustachian tubes, but children with Down syndrome are particularly prone to this. And the eustachian tube is really important because it keeps the middle part of the ear here filled with air and prevents this part of the ear becoming fluid filled, which we'll come on to in a moment. So keep those two key differences in mind as we go through this presentation. So types of hearing loss. We have three main types. We have conductive, sensorineural, and mixed. Now in conductive hearing losses, the inner ear is functioning absolutely fine. However, the sound is not passing or conducting through the outer and or the middle part of the ear as easily as it should do. Now this type of hearing loss is usually, not always, but usually temporary, and it is by far the most common form of hearing impairment in children, particularly those with Down syndrome. The two most common causes of this conductive hearing loss is wax build-up in the ear canal, and you can probably appreciate if this ear canal is very small, it doesn't take much wax to completely block it up. The other common cause is glue ear, and glue ear, you've probably heard about it. It's a build-up of fluid in here, and it is common in all children, and it's so common, and you're bound to have been discussing this with your audiologist. I'll just spend a bit of time talking about what it is and what interventions we offer. So glue ear is a condition where there is a build-up of non-infected fluid, also known as glue or congestion, in the middle ear and the eustachian tube, which prevents the eardrum from moving properly. Now, as I mentioned, the eustachian tube connects the back of the throat to the middle ear, and its function is to keep the middle ear filled with air to enable the eardrum to move freely and enable everything to happen as it should do. In all children, but particularly those with Down syndrome, as I've mentioned, the eustachian tube is very flat and narrow in comparison to an adult. You can see in the diagram here, there's your eustachian tube in a child or an infant, and the adult much bigger, and it's on a slope. Just means it can do its job better. So you might hear the term glue ear, middle ear congestion, otitis media with effusion. It's all the same thing. It's all glue ear. It's basically a build-up of fluid in this middle section here. So the ability to hear in children with glue ear will fluctuate or can fluctuate day to day, or it may be impaired all the time. There may be a few children who are still hearing normally or who will experience only mild hearing impairment, but this is less likely in children with Down syndrome. Right, so a little bit on what we do about glue ear. The first form of support is monitoring. So we may suggest a 3-monthly review, and depending on your level of concern, this may be all that we do. Just see them every 3 months, repeat the hearing test, and just check that it doesn't get any worse. During this time, you may be offered a referral to a hearing support teacher if you haven't got one already, and they will be a fantastic source of information, point you in all the right directions for information about glue ear, management of glue ear, what you can do at home, at school, etc. to help. You may be offered something called an Otovent, and this is something you can have a look into. Basically, it's a little balloon that the child needs to blow up with their nose. So they need to be able to be really good at blowing their nose in the first instance. Therefore, it does tend to be an older child. Depends on your child, but I'd say 4, 5, 6 years plus. And it does need to be used daily and consistently to work. But research does show that in the general population, it reduces the amount of time a child has glue ear. If your child comes back into audiology after that initial monitoring period and they still have a hearing loss, and glue ear and you have concerns, we have two forms of treatment on offer. The one that we will always recommend is hearing aids. And depending on the amount of information we have, we'll either offer a bone conduction hearing device or a behind the ear hearing aid, the conventional hearing aid you're probably more aware of. Now we'll talk a little bit about these options in more detail later on in the presentation. There is another option, the surgical option of grommets. This would involve a day case surgery, general anaesthetic. The surgeon puts a little cut in the eardrum, sucks all that gunk and glue out, and puts in a grommet. Now you can see the grommet is this white thing here, it looks a bit like a polo, and that just helps stop the glue ear coming straight back, keeps the middle part of the ear well aerated. The reason why we don't recommend this as a frontline treatment for glue ear and Down syndrome children is because of those really small ear canals. Because of the small ear canals, the surgeon has to go for a smaller grommet, and smaller grommets just come out of their own accord quickly, and therefore as soon as the grommet comes out, the glue ear comes back. And these days we don't do multiple surgeries. It's not good for the eardrum. You get all sorts of scarring. So that, plus all the downsides of this, which are increased risk of infections, that's why we recommend hearing aids in the first instance. So the second type of hearing loss is sensorineural. Now this is permanent damage to the inner ear or nerves. And these are the types of hearing losses that the newborn hearing screening program was designed to detect. And treatment will usually be hearing aids or cochlear implants depending on the severity of the hearing loss. If your child has been identified with a sensorineural hearing loss at birth, you will be offered intervention straight away. And the type of intervention will depend on the severity of the hearing loss. And we'll come to that in a moment. The final type of hearing loss is mixed. So it's a combination of both conductive and sensorineural hearing loss. So your child may well have been identified with a permanent hearing loss at birth, but then later on we find that they also get glue ear, so they get a conductive hearing loss on top of that. And the treatment that is recommended as a result may change because of that. So once a audiologist has test results, they will plot them on something called an audiogram, which is basically a graph. And on the right there, you'll see a rather colourful version of it. Down the side, you've got the decibels, which is basically a volume. And on this graph, the quieter sounds are at the top and the louder sounds towards the bottom. Across the top, where the piano is frequency, and I've included the piano because that's how I often explain it to parents. On the left-hand side, we have our low bassy tones, and as we move to the right, we have our higher pitched squeaky tones. And the audiologist will plot the quietest sound that your child can hear for each pitch, and that will determine whether your child has normal hearing, whether they have a mild, moderate, severe or profound loss, depending on where those hearing test results lie. And you might be shown the audiogram and you'll see all sorts of different symbols, and if it's ever anything unclear, please do ask your audiologist to explain. They'll be more than happy to. But essentially you'll see red circles for the right ear and you'll see blue crosses for the left. If we're using both ears together, so we're not actually putting headphones on your child, you'll probably see a square symbol. But as I said, do ask for it to be explained, or your hearing support teacher will be happy to go over it with you if you have one. Moving on to hearing and Down syndrome specifically. Now, we've already touched upon some reasons why we might want to keep a close eye on children with Down syndrome, and that being glue ear and wax. However, there are a couple of other reasons why we take a quite a targeted approach to hearing reviews. The first one of which is very rare, but it is a complication of persistent glue ear, and that is cholesteatoma. Now, that is a build-up of skin cells in the middle part of the ear, and it forms like a growth, which starts to erode away at those little bones that sit in the middle part. And if those bones are eroded away, it causes a permanent conductive hearing loss. It's important that these cholesteatomas are picked up in order for them to be removed. Now, the most common sign that a child has a cholesteatoma is a history of persistent glue ear, but frequent persistent ear infections that just don't go away with treatment. If your child has both those, I would encourage, if you haven't had close audiology review, that you get in touch with the audiology department or speak to your GP about your concerns, and you will be referred to an ear, nose and throat doctor who can have a good look and treat any presence of cholesteatoma. And finally, children and young adults with Down syndrome are more prone to early onset age-related hearing loss. We all get age-related hearing loss at some stage, but it tends not to hit us until our 60s, 70s when we really start to notice it. But children with Down syndrome can start to develop this in their teens and early adulthood. So it's important that these regular hearing reviews continue even when you're discharged from the paediatric department. So these early age-related hearing losses can be picked up and treated as per required. Now, us in audiology fully appreciate the huge health burden families are under when one of your children have Down syndrome. Lots of different professionals sending you lots of different appointments. But hopefully today I've highlighted the importance of hearing. But if you're really struggling to keep up with the regular hearing reviews, do just talk to your audiologist, and you may be able to come up with a review schedule that suits you, depending on your level of concern and the sorts of hearing test results that you have had historically. So just open up that conversation if you are struggling. Here are some hearing statistics for you. So in the general population, by the age of 9, 2 in 1,000 children will have a permanent hearing loss, and half of those are born with it. If we compare that to the Down syndrome population, 60 in 1,000 children have a permanent hearing loss. So it's far more common compared to children without Down syndrome. 1 in 5 preschoolers have glue ear at any one time in the general population, but in most cases, so 80%, it just resolves itself and there's no major issues. But we already know, having listened to this presentation, children with Down syndrome are more prone to glue ear. By the age of 1, 93% of children have glue ear and an associated hearing loss. The glue ear starts from an early age, is likely to be more persistent, and they do get it for longer. So in the general population, children grow out of glue ear by the time they're 6, 7, maybe 8 max. Children with Down syndrome, that can last much longer into their teens. I've already mentioned an increased risk of complications because of that persistent nature. But also, hearing loss is harder to diagnose in the Down syndrome population. And that's because really it's because of the delay in diagnosis. So it takes a bit longer for a child with Down syndrome to be ready for VRA. They're a lot more visual. They love just looking at our faces and they ignore the sounds. So we often have to take a few appointments to piece together what hearing levels are, all those pitches of sound. So that introduces a bit of a delay, unfortunately. Sometimes they just need a bit more of an experienced audiologist, someone who can adapt the testing, adapt the games, maybe if they're play audiometry age, who just can modify what they're doing in clinic to enable your child to complete the test. You might find you need to come in a few times over a short period of time to get the full picture. And sometimes we just can't get a behavioural hearing test, and that's when we'll start suggesting things like that, auditory brainstem response under sleep. But talk to your audiologist if you feel like that's the route you need to go down. Spotting the signs of hearing loss can be difficult. These sorts of behaviours can be down to child's Down syndrome or their general personality, but they could also indicate a hearing loss. So the obvious one, they may have difficulties hearing, ask for repetition, they may mishear words, get completely the wrong end of the stick. You may notice they need to turn the TV up or seem to be ignoring you when you call them. You may notice that speech is unclear, delayed compared to their peers. You may notice a change in the volume. They may become louder or even quieter than normal. Their behaviour may become affected, so they may become frustrated, withdrawn, prefer to play alone. They may get easily tired. Listening effort has a huge impact on a child, particularly the younger ones. When we have a hearing loss, we have to try harder, and that is exhausting. So you may notice that their attention is shortened, particularly in noisy environments such as school. You may notice they are particularly prone to mouth breathing, snoring, stuffy blocked nose most of the time. You may notice a loss of independence or low mood. They may turn one ear towards the speaker, so that can happen when you've got one better ear and one worse ear. You may notice your child watching your lips because they're trying to lip read. These signs may be very subtle, especially in busy environments, but advice is talk to anyone involved with your child. So have you got a hearing support teacher or teacher of the deaf who can help you look at these signs? Their nursery worker or their teacher at school, have they noticed anything? And discuss your concerns with them. They may be able to shed some light. And if in doubt, talk to your audiology team, get the hearing review brought forward, or your hearing aid review brought forward, and get another hearing check completed. What can you do at home to help with any hearing loss, whether you use hearing aids or not? There's a simple acronym that I've stolen from a fantastic resource, which I'll put in the reference slide at the end. First one, biggest one, attention. Grab your child's attention before you say something important or say anything. Having that one-to-one contact, it can make all the difference to them. They can see your face, your visual cues, the strength of the sound signal, the volume will be higher if you're facing them. Be aware of your background noise. Try and reduce it if possible. So if you're having quality time, such as say reading a book at the end of the day with them, make sure there's nothing else going on. Turn TV, radios off. If siblings are causing a racket, ask them to be quiet. by doing so, you're making it easier for your child to hear the speech above the babble of noise that goes on in our busy lives. C, clear speech and get closer. You don't have to shout, just pronounce your words clearly, paraphrase. So instead of just repeating the same thing again, if your child asks for repetition, try and say it in a different way. That helps them put all the pieces of the puzzle together and work out what's being said. D is don't smoke. The one thing that can make glue ear worse is a child living in a smoky environment. So if you or a member of the family does smoke, it's best to ensure that's not happening in the house. E, encourage your child to wear their hearing aids if you've gone down that route. It's really important that if you do have hearing aids that they are consistently worn, because it's that consistent level of sound that's going to help. And F, face to face, which links in with attention, but if they can see your face, it just makes it 10 times easier for them to work out what's being said. We briefly discussed different types of hearing aids when we talked about intervention for glue ear, but we'll talk a little bit more detail now. We provide them in paediatric audiology, or if your child has gone down the cochlear implant route, this is provided by a hearing implant program. Now, your paediatric audiology department will be local to you, whereas an implant program you may have to travel to regional sites. The behind the ear BTE, which you can see being worn by the baby here, is by far the most common type of hearing aid. As I mentioned previously, it is important that we have as much information about hearing levels as possible for us to accurately set up the hearing aid. And if your child does have glue ear as the sole cause of their hearing loss or added on top of their permanent hearing loss, it is important that we regularly review them, because we do need to change the settings if hearing is going up and down. The second type is our bone conduction hearing device, very commonly used in the Down syndrome population because they can cope with us having only very limited hearing level information. Only good if we know that the underlying hearing is fine, and by that I mean that the hearing organ is working as it should do. It's just the congestion that's causing a temporary but persistent problem. But they're fantastic for circumstances where we've only got limited information, or where hearing is fluctuating like mad. So if your child is one that 1 minute is absolutely fine and the next minute has a moderate hearing loss and it flips between the two, these cope really well with that. Cochlear implants, you see on this little girl here, are for when your child has a profound hearing loss, severe profound. We don't provide them paediatric audiology. You will be travelling to a regional hearing implant program for that. But those are surgically implanted hearing aids, basically. The bit on the outside looks very similar, it just looks like a large version of this. And then they have a magnet up here which sends the signals into the implant, which is basically a coil of wire that's been inserted into their ear. It's an absolutely fascinating surgery, and it's incredible what a cochlear implant can provide a child with very little hearing. But as I said, only those children with severe profound, they tend to be detected at birth. Now, if your child has a bone conduction hearing device for a permanent conductive hearing loss, your audiologist may well start discussing with you about having the surgical version, which is called a BAHA. So that gets rid of this band here, and you just have a hearing aid that these days is attached via a magnet, as opposed to there used to be a popper. sitting behind the ear there. Again, permanent hearing losses only. But if your child has a permanent conductive loss and is getting on really well with the bone conduction hearing device, it may well be an option for you. So I asked one of our regulars, who has a beautiful little girl with Down syndrome, to offer kind of top tips to parents with regards to your audiology appointment. And number one, which I have mentioned already actually, is to practice wait and go games at home with your child. So if they're of the age where they're too old for that visual reinforcement audiometry, not quite ready to do play yet, practice at home. So get your child to wait, and then when you say go, get them to put a ball in the bucket or start stacking a tower. Gets them used to the concept. You don't have to worry about changing the volume of your voice or anything technical. It's just practicing the essence of the game. That's really useful. She said some departments have social stories on their website, so show your child these to get them used to where they're going and what they're going to do. If you don't have anything site specific for your department, you can find all sorts on YouTube. So yeah, head there and have a look for some videos on audiology appointments. If possible, arrange your appointment at a time when your child is not likely to be tired or hungry. Not 4 o'clock on a Friday afternoon or during their nap time if they're younger. So this mum said much better in the morning, but you might find actually a post-lunch appointment is far more preferable. And most audiology departments will be able to offer you some flexibility there. She said pack a snack for straight after. I think that applies to absolutely everyone, adult, child. Always have snacks to hand. When a child is having to listen for that amount of time, listen for those tiny sounds and sit still and quiet and be good, it's draining and can take a lot of energy. So have something for afterwards. And ask questions. Pretty much every single audiologist I've ever met is kind, lovely, friendly. So please do ask questions. They are more than happy to answer them. Even if they look pushed for time, they can arrange a phone call for later in the day or a following day. There's always a way around it. I know we look busy, but we want to help. So please do ask. So here are some of the top tips for hearing aid use that have come in from our parents. Number one, don't be afraid to ask for help. Audiologists at your appointment or your hearing support teacher be more than happy to help you. Though you can be at the end of a phone call. Alternatively, there's usually a lot of information on departmental websites or in the information leaflets that you get given at your appointments. There's a really simple check you can do to make sure the hearing aid is working, and that is to ensure that it's on and then cup it in your hands. If you listen for the whistle, that will tell you very basically that it's functioning well. If it isn't whistling, you need to change the battery, check for blockages, and have another go. Some children will manage their hearing aids more than others. There's no right or wrong. Just be guided by your child. Obviously, if they're particularly keen and they want to change batteries, that needs careful parenting to make sure they stay safe. Feedback and whistling experience when the hearing aids are in the ear needs to be checked, because that could just mean that the ear mold is not quite in properly. Alternatively, it could mean that there's a blockage, there's a build-up of wax in the ear canal. It might also mean that your child's ear molds have become a bit too small. Refusal, so children may refuse their hearing aids. This is completely normal behaviour. If your child has glue ear, you need to be a bit mindful of the fact that hearing could be fluctuating, so a hearing aid could become too loud. You might find that particular times of day your child doesn't want to wear the hearing aid. So if they come home from school, they've had to concentrate all day, they might want to take their ears out and relax without that sound going in, and that's perfectly fine. You can make hearing aids fun, believe it or not, give them a sense of ownership. Some audiology departments will provide coloured aids, others won't, but all of them should be able to give you fun stickers to put on the aids to customise them for your child. Hearing aid stickers can also be very helpful for you to work out which is the left and the right aid. If there's a difference between your child's hearing between ears, it is important that the left aid only goes on the left and vice versa. When the hearing aids are on the ear molds, this is obviously really easy to work out and with a bit of practice, but when they come off, it can be a bit challenging to know. Now, all audiologists will put markers in the hearing aids, a red one for the right ear and the blue one for the left ear, but these are tiny. If you're unsure where they are, ask your audiologist, or alternatively you can use stickers for a sticker for the left and a sticker for the right, so you know what's going on without having to get your magnifying glass out. Retention options do exist. Now, around the age of 9 months to about 18 months, children are notoriously bad at removing their hearing aids because it's a big game, a bit of fun, and it gets their parents' attention. There's various options from hats, toupee tape, retention clips. Ask your audiologist or hearing support teacher if you can't find anything, and they'll be able to signpost you to appropriate companies. So these are my top resources, and if you read absolutely nothing else, read Hearing to Succeed and Achieve, which you can find hopefully via the link. If not, head to the Ewing Foundation or just Google Hearing to Succeed and Achieve. Everything you need to know is pretty much in that very well created document. You've got the Glue It Together website, which again has some fantastic resources in, and we'll link you with that Hearing to Succeed document. Here Glue Ear is also pretty good, and a bit more. There's lots of research on there if you really want to fully understand Glue Ear, its impact, and what you can do about it. Down Syndrome Association has written a health series on hearing. Again, loads of information in there, really well written, a bit more in depth than the Hearing to Succeed and Achieve. So if you wanted more, head there. And you've got the NICE guideline. Now, if you really want to deep dive into management of Glue Ear, that's the place to go. And that is the end of today's presentation. I hope you've enjoyed or taken home some useful hints and tips, or if nothing else, found it a little bit interesting. I'd love to know your feedback, because this is the first time I've offered this e-learning. So please do let me know whether it set your expectations, whether there was anything you'd like to hear more or less about. Thank you very much. Provide that feedback back to DS UK, who can forward it on to me, and that'd be much appreciated. Thank you for listening today.